Hello, everyone. We are here today with AKEDA, and I wanted to go ahead and introduce Beth Rose, who is here with AKEDA, talking about rural healthcare today. Beth Rose is a co-founder of the Alaska Eating Disorders Alliance, AKEDA, a new nonprofit that was formed in September 2019. Both Beth and her co-founder, Jenny, were members of the same book group for more than 15 years before they discovered that they each had an eating disorder when they were teens, and that they each had a child who was struggling with an eating disorder. With firsthand knowledge of the difficulties of navigating this complex, frightening, and overwhelming journey alone, they decided to launch AKEDA to ensure that Alaskans would have local connections, resources, support, and a community to address eating disorders. AKEDA's programs include education and outreach, support groups, advocacy, and body positivity initiatives. The Alaska Eating Disorders Alliance is proud to be a member of the NEDA network. Beth is excited to be a part of this program and to talk with fellow board member Dr. Rachel Lester.
Great. Thank you, Lauren. I'm excited to participate in this important conversation today and would like to introduce our speakers. So our speakers include Dr. Rachel Lester, who's a pediatric endocrinologist in Anchorage, Alaska. She grew up in Missouri and attended college and medical school at the University of Missouri-Columbia. Dr. Lester completed her pediatrics residency at the University of California, Irvine, and then moved back to Missouri to complete her pediatric endocrinology fellowship at Washington University in St. Louis. In 2011, she moved to Alaska to provide pediatric endocrinology care for the Alaska Native Tribal Health Consortium, a unique tribal health system that serves Alaska Native and Native American people throughout the state. In her practice, treating children and adolescents with chronic hormone conditions and providing gender-affirming hormone therapy, she often works with youth who have co-occurring eating disorders or who have endocrine consequences of their eating disorder. In this presentation, Dr. Lester will talk about some of the challenges of and solutions for accessing healthcare and other resources in the last frontier, particularly now during the global pandemic. She's joined by Dr. Yolanda Evans, who is a member of the Division of Adolescent Medicine at Seattle Children's Hospital and Associate Professor of Pediatrics at the University of Washington School of Medicine. Dr. Evans grew up in Alaska and earned her MD from Oregon Health and Science University and a Master of Public Health degree at the University of Washington. Dr. Evans completed her fellowship in adolescent medicine at Seattle Children's Hospital and the University of Washington. Dr. Evans provides care to patients in Seattle, Everett, and Olympia, Washington for a variety of concerns, including eating disorders, obesity, reproductive health, and ADHD. She offers consultation via telemedicine with the Alaska Native Medical Center for management of adolescents with chronic illnesses, including eating disorders and gender-affirming care. Her clinical and research interests are in the areas of technology use to reach adolescents and their families, including the use of telemedicine and video conferencing for patient care. From 2011 to 2019, she was the author and editor of the parenting blog, Teenology 101. So now I'd like to turn it over to Dr. Rachel Lester to start off this conversation, and Dr. Yolanda Evans will join her in continuing the conversation.
Thanks, Beth. So I am excited to talk with you all about providing care here in Alaska. It's a really unique thing that we get to do. I'm just going to show you a couple of quick slides on what the healthcare landscape looks like in Alaska. And so, let's see here. You should be seeing not my niece and nephew, but the what things look like here in Alaska. So Alaska is a frontier area, which means that.
Excuse me, Rachel.
Yes.
This is Beth. We're saying actually something else. We saw the slide, but it went away, and now we're seeing something else.
Okay.
There we go.
Okay. So Alaska is a frontier area, which means that the population density is such that there are fewer than 7 people per square mile, with the exception of Anchorage and Fairbanks area. Basically, the whole rest of the state counts as a frontier area. So that causes a lot of challenges, geographical. So if you stretch the state of Alaska across the U.S., it reaches both coasts. And so obviously that means there's a big challenge in terms of travel and trying to see people when you live in basically Missouri and you're trying to see someone in California. Um, and transportation also causes a lot of difficulties since most of the state is not accessible by road because of all of the beauty of Alaska, such as the mountains and glaciers and tundra. Most of the state is covered by airports. So in a time of coronavirus, when there are travel restrictions and people aren't flying, that is especially understood. And then we also have healthcare provider shortages in terms of both specialty providers and physicians, nurse practitioners, and physician assistants, not to mention other disciplines like nursing and case manager support, dietitians, and mental health specialists and dentists. So, and not only that, but most of the specialists live and work in Anchorage, which is right here where the little yellow dot is, compared to where the whole rest of the state also has people in it who need care. And then we also have quite a lot of diversity in Alaska. There's a lot of language diversity. So with the Alaska Native population, there are a lot of different languages spoken, a lot of different cultures that work together and have their own unique histories, unique pasts. People have lost a lot of their language because of colonialization and forced use of English and historical trauma, but there's still a lot of different cultures that are represented in the state. Not only the Alaska Native and Native American population, which is where my heart lies, but we have a big refugee population, a lot of people that come in from different businesses like fishing and oil and the military. So with all of that, we have some different healthcare challenges, some risk factors that can lead to several communicable and non-communicable diseases, but we also have lots of protective factors in terms of community support. So that's what our healthcare looks like, and then we have developed a lot of resources to sort of meet those challenges that hopefully we'll get to talk about today. And then now I just have to remember how to unshare my screen. And I looked it up before and I just have to remember how to do it. Stop sharing. Okay, there we go.
Thank you. Can you hear me, Dr. Lesher? So it sounds, I know Alaska is definitely, a unique place and just a different landscape. And just wondering if you can maybe talk a little bit more about some of the patterns related to eating disorders that you might see in the clinic population.
Yeah. So as Beth said, I'm an endocrinologist, so I see kids and teenagers with hormone problems. And so for my personal practice, it's sort of skewed. I work with kids that have chronic diseases like type 1 diabetes. I also work with kids who have medical complications related to obesity. And then I also work with transgender kids to provide gender-affirming hormone care. And so a lot of the kids that I see will come in with either like co-occurring problems related to their chronic disease. For example, kids with type 1 diabetes, some will try to take some of that control back by skipping or omitting insulin or changing the way that they eat so they don't have to take insulin, different kinds of food restriction, or finding ways to take less insulin so that they can force themselves to lose weight. So those are some of the things we'll see in that population. With our transgender kids that you and I work together with, Yolanda, we see a lot more food restriction. And then the kids that I see because of complications like amenorrhea or thyroid disease, menstrual irregularities, or low bone density, it seems to be a combination of various disordered eating behaviors. In the statewide, I don't have a lot of good information on that. As far as I can tell from some of the behavior surveys and community and population surveys, it's not one of the questions that they generally ask about, or at least it wasn't in the most recent youth risk behavior survey. So I don't think we have great data, so it's a good opportunity to learn more.
Definitely. I'm also wondering if maybe you can tell a little bit about the model of care, because the healthcare system that you and I are working with is really unique. Maybe we can talk about that.
It is a very unique system. I think it's an amazing system. When I interviewed here in 2010, I was really struck by how focused our healthcare system is on overall health. So I work for the Alaska Native Health Corporation, and it is a tribal health system, but it's different from other Indian Health Service sites where it's run by Indian Health Service. In Alaska, because of a law that was passed during the time of Nixon, actually, they were able to have self-governance. And so the tribes actually own and operate the Alaska Native Tribal Health System and the various tribal health organizations. And each tribe individually owns and operates their own tribal health organization, which is located in the various regions of the state. And then we have the Alaska Native Tribal Health Consortium, which is kind of like an umbrella organization that helps support all of the local and locally owned and operated tribal health organizations. And so it's kind of a three-tiered system. In the villages, in the rural villages where people live out in rural Alaska, we have health aides, community health aides, who are people who live and work in that community and have received training. It's a really sort of groundbreaking program. So they receive training to be the front lines of healthcare in that area. And there's anywhere usually from 1 to 3, sometimes a little bit more, depending on kind of the region, health aides in a single village. And villages range anywhere from 50 people to a few hundred people. And then the health aides, if they need to refer out, will refer to their regional hub, which is where the tribal health kind of hospital or local clinic is based. And that usually includes, various providers, sometimes pediatricians, sometimes OB/GYNs, and then usually a lot of case managers, and then mental health professionals and dietitians, plus or minus. Sometimes we have great access to those. Sometimes people move on, and so that's not always consistent, but really wonderful people in those organizations. And then if people need a higher level of care, then they get referred to the specialty care, which is mostly in Anchorage, where I work and most of the other specialists work. And then we provide care mostly in Anchorage, but most of us also do field clinics out in the various regions and also do a lot of telemed to try to reach people that way. The funding comes from Indian Health Service, but like I said, the actual organizations are owned and operated by the tribes.
And I think, it's such a unique model too, to have, I know in Anchorage, all the different specialties that a person might need for the eating disorder support right there. So maybe how has telehealth kind of changed the landscape a bit for access to support?
Fortunately, we have a really robust telehealth department here at ANTHC. And so I've been working with them since 2012, doing video appointments. But long before that, they were doing what they call store and forward, where using kind of a telehealth software and hardware system, people could communicate that back and forth more easily between the regions. And so with my clinic, for example, we are able to see patients at anywhere. If there's a village clinic that they can go to. And just now with coronavirus, we're also working on making sure we're able to see people at home too, in case they're not able to go to the clinic for whatever reason. And then we can sometimes involve the dietitians or behavioral health consultants that are part of our team. We have a team-based model here, and so we can do some team visits with the providers. We haven't started doing team visits with the patients, but we're able to provide that care, especially in regions where there isn't a dietitian or a mental health professional, or isn't, if there's maybe one or two for a whole region, they're stretched pretty thin.
Mm-hmm. Yeah, it's amazing to be able to, even before the pandemic, kind of have access to the different team members for the patients. So it's just a really amazing model. I'm wondering too, like, what are, like, thinking about the population there and just maybe elaborating or telling a little bit about the challenges, like why telehealth is so important, because there's seasonal, there's economic, there are all these challenges.
So some of the challenges I spoke about, like geographic challenges, but we definitely have economic and resource challenges. So lots of people still do subsistence hunting and fishing, but that is limited by the season. So if the fish aren't running, or maybe it wasn't a great fish year, then maybe you don't get as much salmon that year. If the caribou herd isn't really thick that year or something, then that could affect people's resources. Berry picking is only during a certain time of the year. Depending on what region you live in, food may or may not be able to be grown. You can have some certain foods grown on the tundra, like fiddlehead ferns are really yummy, but the resources that people have access to are variable. And then additionally, with climate change, we see changes in the resources that people used to have. And then there's also been a change in the way people eat, and be from subsistence to having more store-bought foods, which are typically expensive. They're often sparse, especially if the planes aren't flying, or what's available is not particularly nutritious, and so those kinds of things can really affect what people can find to help with their health. And then the money kind of flows where the jobs are and where the fish are, if they have, if you have a job with fishing or a job with the oil. So those things are really variable and dependent a lot on the current climate and resources. And so to meet those challenges, being able to do telehealth and the field clinic visits and having kind of the healthcare resources sort of spread out has made it more realistic to be able to try to help people where they are.
I think kind of thinking about just all the different uniqueness of Alaska, and you mentioned all the different cultures and the different languages too. How have you experienced the effects of cultural differences or cultural themes in eating disorder presentation and care?
I was thinking about that when we were talking, and one of the things with culture that I've seen is when we're able to do video visits, often the health aide is there in the visit as well, because the cultures are so very different, even from village to village within the same tribal system, or within that same, like, maybe group of people or the same language group, but there may be different cultures even within that village. And so having the health aide available to maybe be that kind of cultural translator, cultural interpreter, has been really helpful. And then our hospital really works hard to employ Alaska Native and Native American people, so that there can be, again, sort of that understanding, at least, and maybe of a culture that person works within, or the language, because we do have some people who really don't speak English very much, or it's really a second language for them. In terms of eating disorders specifically, I think it's so variable that I haven't really seen a specific pattern. Some people are less willing to talk about things than others. Some people everyone has different levels of feeling shame, or comfort in talking about things. So I haven't seen a specific theme, but we're fortunate to have those sort of cultural interpreters.
And I know we haven't really talked at all about how we work together too.
Yeah, we talk too much.
There's
So
not a lot of
I'll
time.
go quickly that you are such a wonderful resource for me. So Yolanda gets to do telehealth from Seattle with patients in Alaska. And we piloted together because my case manager is your case manager. And so we're able to share a lot of patients, and I've gotten to learn so much from you through just working with you, but also through the LEA training program. So I'm super excited to hear your talk on Monday.
I know. So yeah, I think ditto. It's been amazing, an amazing experience to go back and forth and learn from each other. So thank you.
Yeah. Thanks for letting us speak, Beth.
I'm going to jump in and just thank you both for this incredible overview. I mean, we absolutely could have had an hour or more of this because it is complex and there's so many different cultures and languages and approaches. But I really appreciate even that you could share a little bit about how you work with Alaska Native tribes and patients, and Dr. Evans, how you coordinate with Dr. Lesher. And on Monday at 10 o'clock Alaska time and 2 o'clock Eastern time, Dr. Evans is going to be back to talk about telemedicine. And I know that she and the Seattle Children's Hospital has been just a leader in this, especially in providing team care approach for eating disorders. So I think it's really exciting, and I'm grateful for your conversation on this. So, and I think this will be on the NEDA website under NEDA Connections later, so we can refer other people to see this. So I guess I'm going to say thank you so much, and then we're going to close it out now. So,
Thank you.
all right, take care. Bye-bye.
Bye.